But every animal research we've been doing is related to clinical practice, so I will share our recent data with you as well. So physiology, the only reason why you give fluid to your patients is to improve oxygen delivery, to improve cardiac output via improving stroke volume. So in other words, to deliver more oxygen to the mitochondrium. This is the only reason you give fluid to your patients when we talk about hypovolemia, to get this imbalance between oxygen delivery and consumption better. Now, what happens if your patient becomes hypovolemic? There's no really problem at the beginning, because if the oxygen delivery is dropping due to any reason, let it be hypovolemia, oxygen uptake, VO2, by the cells will remain static for a considerable length of time. However, beyond a critical point, all the compensatory measures become exhausted, and beyond this critical point, any further drop in oxygen delivery will result in lack of oxygen in the tissues. And this can be detected by an increase in lactate. The process can be detected via a not very typical drop in SCVO2. But by and large, beyond this critical point, there are two things happening at the same time. One is oxygen deficit and oxygen debt. And these two things are not identical. This is a very elegant animal experiment. Dogs were bled and then resuscitated. Now, the white arrows indicate oxygen deficit. And oxygen deficit at this point of time and a bit later on increases from 30 mils per minute to 40 mils per minute, or 40 odd. But oxygen deficit is basically the area under the curve, the area of this triangle. So it is the time elapsed while the animal was in oxygen deficit. So oxygen debt is in fact triples over the time, while oxygen deficit just doubles or less than doubles. And then you start your resuscitation here. Oxygen deficit decreases, and then it becomes 0 at time 4. However, oxygen debt is accumulating during that time. So this animal is in severe oxygen debt, and you have to repay this oxygen debt. Now, what they did in this animal experiment, they repaid the debt. Now, it means that the area in this box should equal to the repayment box. Now, what they did in the first group of animals, they gave 120, I'm sorry about the slides, I don't know what happened, but 120% of the shed blood volume, 30% and 15% of the shed blood volume. And what happened was that in these animals, oxygen was repaid, no problems with organ function. However, in these two groups of animals, there was organ dysfunction, vital organ dysfunction, and all of these animals in whom resuscitation was delayed and could not repay oxygen, that they died. So the message of this very important experiment, that when you resuscitate your patients, the faster, the better. Now, if we go to this well-quoted Starling 3-compartmental model, fundamentally you give 3 types of fluids to your patient. You give water in the form of 5% dextrose or glucose, you give crystalloids, and you give colloids. Now, water is distributed all over the total body. Water separated the 3 compartments by the endothelium and the cell membrane. Crystalloids, because the fundamental cation in crystalloids is sodium. Sodium cannot enter really the cellular membrane, so it will be distributed in the extracellular water. And colloids, by definition, are macromolecules, should remain intravascularly. Of course, it's not that true, but by and large, this is the situation. Now, if your patient is thirsty, dehydrated, you should give water. When you are thirsty after a partying during the night, you drink water, okay? But when your patient is hypovolemic, you have 2 choices. You either give colloid or crystalloid. Now, the thing is that the volume replacement ratio, following Starling's principle, that you replace 1 unit of blood loss by 4 units of crystalloid, or fundamentally by 1 unit of colloid. So if we go back to this assumption that resuscitation, the faster the better, then colloids may have a place, because you can resuscitate your patient 4 times faster with colloid as with crystalloid. Now, the question is, does the Starling's principle work in our patients? So let's go back to this, and what I'm going to follow in the next part of my talk, whether this relationship of a volume replacement ratio for colloid of 1:1 and crystalloid of 1:4, is it a fact or fiction? If we look at the, this is what happens when you design your presentation in Macintosh, okay? And then it is presented via Windows. Anyway, the message will still come through, don't worry. This is the SAFE study, 7,000 patients in Australia and New Zealand randomized into an albumin and a saline group. There's nothing to do with the Starling principle. Only 25% more saline was given for resuscitating these critically ill patients. But you must read the paper, don't just the conclusion. And when you read the methods, when did they give fluid? When the treating clinician judged that fluid resuscitation was required. It was a gut feeling, okay? This is the Scandinavian study, the 6S study, and they randomized for 800 patients. And look, identical amount of crystalloid and colloid was given to these patients during resuscitation. Read the methods, and the methods say the trial fluid was used when ICU clinician judged it was needed. Again, gut feeling, nothing else. 6S, the chest study from New Zealand, Australia, thousands of patients included. Again, only 20% more saline was administered to these patients during resuscitation. Read the methods. What does it say? A trial fluid was administered as determined by the treating clinician and supported by at least one objective physiological criterion. What were these? It was mean arterial pressure. It was heart rate, and CVP and lactate. Look at that. 50% of patients had a lower heart rate than 90 per minute. Patients were hypertensive, mean arterial pressure higher than 75 in 50%, CVP higher than 9, and the lactate lower than 2 in 50% of patients. So my assumption is these patients were not hypovolemic at all and received fluid resuscitation. Christmas study, they included urine output and SCVO2, but again, when you look at the results, there were only the patients in the saline group received only 20% more fluid than patients in the colloid group. So the common feature of these studies, that indication of fluid bolus was based either on gut feeling, intuition, or absolutely inadequate hemodynamic indices, and rather than invasive hemodynamic variables. So there's no conclusion. There's one conclusion, that our everyday practice at the bedside is inadequate and may potentially be dangerous, because if you give synthetic colloid to a patient who is not hypovolemic, you do harm, full stop. Now, let me introduce to you, although Gianninci has left the conference, Hemodynamic Coherence, and this is his review in critical care recently, 2 years ago. And hemodynamic coherence means that macrocirculation and microcirculation must be coherent. So in other words, when you do correct your macrohemodynamic parameters, these should correct microcirculatory perfusion and oxygen delivery. And this is exactly what we've been saying for several years now. And this is a chapter we published in the annual update in 2014. What it means, and these are my co-authors, both of them wrote their PhDs on hemodynamic monitoring, that you must put oxygen delivery and consumption into context. And of course, there is tissue perfusion as well. There is no way out. You have to use this multimodal approach if you want to do the best for your patients. And of course, the glycocalyx has a huge impact in this game. These are my current PhD students. In fact, Ildiko has left the team now. And we wrote another chapter in the annual update this year. And this is something what we did, that the glycocalyx, of course, when it is normal, it has several important functions, but in critically ill conditions, it becomes damaged, and then permeability changes. And now the question comes that, does the Starling principle work in our patients? Well, let's see. If you look at animal models, these are all bleeding resuscitation animal models. And in these, because these are healthy animals, then the crystalloid-colloid replacement, volume replacement ratio works. Starling's principle works in healthy animals. Now, these trials were not designed to test the hypothesis, but so we designed an animal study, and what we did, we bled pigs till they dropped their stroke volume by 50%, and then we resuscitated them to reach the baseline stroke volume. And we randomized them into a crystalloid and a colloid group. What you can see here, that patients in the crystalloid group received more fluid, of course, and the volume replacement ratio was exactly how Starling suggested. So these were healthy pigs, bled and resuscitated, moderate bleeding resuscitation. Why? Because their glycocalyx remained intact. Although there was a significant drop in syndecan and glypican levels, but when we corrected them for hematocrit, this was just a dilutional effect on the glycocalyx. So these animals' glycocalyx remained intact throughout. So the crystalloid and the colloid followed the Starling principle. So it works when your patient's glycocalyx is intact. So this is what we did. I don't know your surgeons, but my surgeons in Szeged, they believe that colloids improve microcirculation. So we had to test this hypothesis. What we did, this is the maxillofacial theater. It's a free flap to replace the destruction on the face. And what we did, we randomized 30 patients into a crystalloid and colloid group. We applied multimodal monitoring. All of these were taken into account, and we felt that the patient is hypovolemic. Patients received either crystalloid or colloid boluses. And we measured the microcirculation with laser Doppler. Now, what we found, that patients in the crystalloid group received more crystalloid. When we look at hemodynamics, stroke volume, cardiac output, mean arterial pressure, patients were steady, stable throughout the 8-hour-long surgery, okay? And no difference between noradrenaline need, dobutamine need, and urine output. So the patients were hemodynamically stable, and this hemodynamic stability was achieved with both fluids. So we measured microcirculation with laser Doppler. We put one probe on the control site anywhere on the body, and another one on the flap, on the free flap. And this is the data, crystalloid colloid in the normal area and crystalloid colloid on the flap. You can see that there's no difference whatsoever in the microcirculatory perfusion between crystalloid and colloid group. In the flap group, in the flap, there is no difference either, but because it is denervated, the perfusion increases. When we did a heat provocation, then of course the normal area changed, the flap didn't. So by and large, the message of this, that in crystalloid and colloid regarding microcirculation, there is no difference whatsoever if you get the hemodynamics right and the glycocalyx is intact. These were patients for elective surgery, and they remained hemodynamically stable. We are about to publish this paper short. When we go back to critically ill patients, all the studies I have shown you, and this is all the studies which compare crystalloids to colloids. And the problem with this, that what you find, that yes, patients received only 1.5 times more crystalloid, the most, or identical amount of crystalloid as compared to colloids. But don't forget that none of these studies employed detailed hemodynamic monitorings. There is no message in these papers apart from the fact that our everyday practice without invasive hemodynamic monitoring is wrong. Totally, utterly wrong. And indeed, this is the last slide I'm going to show you, that when we gave LPS to mice and we measured the thickness of the glycocalyx, we have a special new software to do that, and we measured glycocalyx degradation products. Within 18 hours, the glycocalyx almost disappears from the animals, and the degradation markers triples. So there is a problem in critically ill patients. So the Starling's hypothesis may not work when the glycocalyx is damaged. As simple as that. So instead of summary, what we do recommend is a multimodal, individualized, monitoring-based therapy in critically ill patients and in high-risk surgical patients. There is no way out. Everything is revolving around oxygen delivery and consumption. These are my co-authors in this current paper. So these are the measures you can assess microcirculation. This is how you can treat those which are abnormal, and then you have to reassess. It is very complicated, but nobody said life is easy in intensive care, and thinking has no alternative. Thank you.